Scientists at Duke University and UC San Francisco have shown that early trauma is associated with greater erosion of telomeres, the protective end caps on our DNA, and without telomeres, ACEs may prematurely age a child at a cellular level. And there's a neurocircuitry known as our default mode network, which is a collection of brain cells responsible for regaining the quiet idle we all need. This network helps us hum along at baseline and unites memories and thoughts, but at the University of Toronto, they found that kids who experience chronic toxic stress have this default mode essentially go offline. They don't have it anymore. They no longer can figure out what is and what isn't relevant, and they're overreactive in everyday life. There have been several studies looking at parental ACE scores and child development. In the study of developmental progress at 24 months of age, parents were given the ACE survey. About 50% had ACE scores of 1 or greater, 20% at 2, and 12% at 3 or greater. These were very similar to the Kaiser findings. And it was remarkable that with every single ACE point, concerns about developmental delays increased 18% per point. Researchers from Children's Mercy Hospital in Kansas City showed a strong correlation between parental ACE scores and their child's adverse experiences. So with a parental ACE score of 4 or greater, children were 10 times more likely to be homeless, 10 times more likely to be homeless, 44 times more likely to witness intimate partner violence, and 12 times more likely to experience emotional or physical neglect. And in Pediatrics from 2016, families where children themselves have ACE scores of 3 or greater by the age of 5, their likelihood of academic and behavioral problems in kindergarten is much higher. For example, 3 or more ACEs is associated with an 80% increase in language literacy and math skills being below average, a 350% increase in attention problems, a 270% increase in social problems, and a 230% increase in aggression compared to with kids of scores of 2 or less. And finally, from a research standpoint, the timing of ACEs is even more surprising. We now know that 50% of all ACEs are experienced by age 3. In children from high-risk families, the numbers are even more concerning. The Quality Improvement Center for Research-Based Infant-Toddler Court Teams supports work in 11 sites around the country, and they implement innovative approaches to families who are in the child welfare system. And in their population of kids under 3, they found average ACE scores of 4.1, under 3 years of age. And 59% of these had ACE scores of 4 or more, and 1 out of 4 had ACE scores of 6 or greater. So ACEs happen early in our lives, strongly suggesting that identification of high-risk kids and their families, as well as strategies to address this issue, needs to be prioritized. And as you know, in the jobs that we all work, we deal with the end of the river, the delta, don't we? We're missing the upstream opportunity because the damage has been done by the time most of us end up seeing our patients and clients. So in essence, early childhood exposure to toxic and chronic stress creates internal changes in regulation of our stress hormone system, increasing cortisol, epinephrine, and as we marinate in these levels, high levels for years, our brains are changed. In architecture, in neurochemistry, our DNA is modified, resulting in changes of stress-related gene expression. And all of these phenomena have great potential to create an emotionally and physically dysregulated child who are constantly readying themselves for the next fight or flight. So what about the ACE study? The ACE study out of Kaiser Permanente in 1995 really started this whole discussion, and it has gained a lot of attention, thankfully, in our respective fields of mental health and pediatrics. And it was really a brilliantly developed study with the following hypothesis. Are there any connections between adult diseases and traumatic experiences in childhood? That was the question. The study was a large scale with over 17,000 participants and looked at mortality data, disease prevalence, health risks, social functioning, and medical costs. And the take-home message from the ACE study by Kaiser was that ACEs are the prime determinant of adult health. In the study, there were 10 adverse childhood experiences. 3 were abuse experiences, psychological physical and sexual. 2 were neglect, emotional and physical, and 5 were household dysfunction ACEs. Chemical dependency in the home, separation or divorce of parents, mental illness in the home, including suicide, witnessing domestic violence, and imprisonment of a close household member. These 10 ACEs each had typical average prevalences, with 10 to 15% of adults experienced different forms of neglect as children, 11 to 28% different forms of abuse as a child, and 5 to 27% different forms of household dysfunction. 33% of the people had an ACE score of 0, and 2/3 had ACE scores of 1 or greater. 1/4 of the participants had ACE scores, 11% of the ACE scores of people had ACE scores of 5 or greater. And women were 50% more likely to be in that high ACE score group. The relative risk for a variety of diseases was determined based on chart reviews, and really stunning correlations were found, especially for people who had ACE scores of 4 or more. For example, adults with ACE scores of 4 or more were almost twice as likely to develop cancer or have recurrent miscarriages, over 4.5 times more likely to have depression, and 7 times more likely to have alcoholism. Additionally, ACE scores over 4 increased relative risk of suicide, over twice that of people with ACE scores less than 4. And if a person had an ACE score of 6 or more, the risk of suicide was 30 times. There are other adverse experiences that many believe should qualify for ACEs besides these 10. In 2016, the National Survey of Children's Health proposed 7 new ACEs: poverty or family financial situations, food sensitivity, homelessness, parental absence from things like deportation, extended military leave, or job-related, parental or sibling death, bullying, and witnessing a violent crime. I believe there also might be ACEs related to parenting styles. There might be daily fights or arguments about technology. Has anybody dealt with families like that, where they're constantly yelling at each other over something as silly as a tablet? What is that doing to the child? Parents who overly pressure their child to perform, or parents who incessantly talk too much. That's why one of the chapters in our book is called Just Shut Up. It's not for the kids. Some parents are very inconsistent in their approach, and it causes a lot of stress to their kids because they really don't know what's going to happen. And of course, excessive shaming. And we've all been in rooms where parents are constantly pointing out the failures of their child. You can just see it in the faces and in the body language. But the fact is that toxic stress in childhood connects adverse experiences to poor outcomes in adults. This should have our attention. So how does trauma affect kids at different ages? This is a real interest of mine. And as you would predict, developmental stage and level of maturation will manifest trauma symptoms differently. So a child who is developmentally advanced might experience symptoms of a child who's chronologically older, and vice versa. A child who's delayed may have symptoms of a younger child. With all that said, every symptom in childhood stress is related to a dysregulated HPA axis and a lack of social emotional buffering. And almost universally, most ages of children experience changes in sleep and eating, emotional roller coastering, lots and lots of anger, unreasonable fears, and distorted reality. The very young child, up to age 2, who is experiencing a lot of stress at home, typically shows high levels of anger. Most of the time, the terrible twos start in that second year, but toddlers who experience high levels of stress, it takes on a new level. It really does. This kid is angry, aggressive, and difficult to soothe. She may take a long time to calm down. He or she will likely have sleep difficulties or other things like sleep onset association disorder or problems with frequent waking. The nighttime insecurity is a common feature, and the very young child typically becomes terrified when responding to discipline by a caretaker who is physically or emotionally abusive. When I see a young child in this situation, and I have had a 16-month-old in my behavior clinic, which is like, wow, 16 months and they're angry and out of control. When I see this, I think it's very, very important to unpack the family dynamics looking for toxic and chronic stress. The preschool age is a little bit different because it has the language development involved. These kids will lose it, but when something doesn't go the way they thought, their track to a high arousal state is very fast. At this age, we start to see a pattern of verbal abuse. These are 3-year-olds who are swearing and saying very nasty things, first to their immediate family and then outside the home, like teachers or daycare providers. It's common to hear them say precociously vulgar things to others, which is almost always a reflection of what is said to them at home. In academic settings, these kids struggle with attention and focus and behave in constant agitation and lack self-confidence. The 6 to 12-year-old suffers their consequences in the form of peer relationships. Because of the unregulated anger and overt aggression, the social ramifications are really big for this group. These kids are bossy and controlling, and their peers are turned off by their overreactions to very normal situations. And this all leads to an inability of peers to trust them, and they can become loners, struggling to make or maintain friendships. And what follows is a lowering of self-esteem and thoughts of self-harm and even suicide at this age. Suicide now in 14 to 25-year-olds is the number 2 cause of death. It's the number 4 in 10 to 14-year-olds. The teen and young adult experience an intensification of the symptoms as we see in elementary and middle school. It can be very verbally abusive, especially towards their parents, their family, and they start to medicate with medications, drugs, alcohol, risky sexual behaviors. This age is also known for a myriad of unexplained somatic complaints, including headache and stomachache, malaise, fatigue, fainting, sleep problems. And as I work with my residents, when this diagnostic dilemma adolescent patient comes in, where nothing they're telling you makes any sense, medically or physically or anatomically, a thorough evaluation of trauma really needs to happen. Teenagers who experience high levels of stress also suffer from panic attacks, OCD, hoarding, and eating disorders. The cost of evaluating kids with trauma is massive. In a study of survivors of child abuse and child neglect, the cost of healthcare was substantially higher and the lifetime productivity substantially lower. Costs associated with the child welfare system, criminal justice, and special education were all much, much higher in these kids than kids who did not have abuse or neglect. And these are 2004 numbers, 14 years old. So we know that traumatized children consume more health care, need more mental health services, and have long-term morbidity associated with their trauma. When I started my current faculty position, I was amazed at the number of patients who had been seen dozens of times for the same issues that didn't make any sense, had no concrete diagnosis, had not responded to a variety of medical interventions, and had undergone excessive testing. And this is not unusual in pediatrics if you practice in the suburbs or the inner city. What was curious to me, though, in many of the cases, the patient and family had never been screened for toxic stress as a possible home contributing factor. I want to change course just a little bit and talk some about mass trauma because it is in the news a lot. I'll talk about the news in just a second, too. And there's a growing body of research that's been produced since 9/11 and the age of terrorism, as well as the rash of mass shootings and school shootings. As you know, there are several different forms of trauma. Natural disasters can be a form of mass trauma, like hurricanes and floods, and in Hawaii right now, volcanoes. When these occur, kids will inevitably see the reports or posts online and have questions. Sometimes mass trauma occurs as mass shootings or school shootings, and we all know that too well: Las Vegas, Orlando, Parkland, Columbine. Those names still haunt us. But what's different today compared to, say, 1965 is our access to watching a mass trauma event as it's happening and long after is so different today. Our 24/7 news day has changed our exposure to violence in the world. And in the 70s, those of you who remember Walter Cronkite, the evening news was on for 30 minutes, and that was it. The news was delivered in the form of facts, not opinions, in a neutral way, not with emotions. Now we watch what happens on the news over and over with extensive commentary editorialization and punditry, and we see graphic depictions of each tragedy, usually without any warning, in slow motion and zoomed in. News is now filtered through political and editorial lenses and leaves little for the consumer to process or decide. It's simply decided for you depending on the channel you watch. Additionally, the amount of anger that we're seeing from mass trauma especially is astounding. Most everything has become yelling and blaming, with very few examples of people with different views actually listening to each other. And I contend that all of this is very damaging to our children, and probably us as well, because it creates yet another source of toxic and chronic stress. There are many misconceptions about large-scale trauma and its effects. One misconception is that everybody with mass trauma experience develops PTSD. That's simply not true. Many believe that the severity of your trauma will determine the severity of your PTSD, and that's not true. Some think that talking about trauma will make things worse, kind of like a self-fulfilling prophecy, but that's not true. Many experts agree that even interviewing child eyewitnesses on national television right after a mass trauma, like a school shooting, may be much more traumatic to the child who's being interviewed than the trauma would have been itself. Finally, some people believe that kids who have experienced mass trauma should immediately talk about it and engage in therapy, yet every child, as you know, is different and needs to be given the freedom to process their trauma when they're ready. PTSD is an interesting animal. After mass trauma and individual trauma, it's certainly a possibility. There are some things that make PTSD more likely to occur, like a high risk to life threat. Interestingly, the biggest factor for developing PTSD has more to do with past trauma history than the trauma itself. This is a reality that's also seen in studies looking at the likelihood of PTSD in returning armed services combat personnel. For children, their own pre-trauma history of interpersonal violence by a caretaker or significant other will increase their likelihood of developing PTSD after an individual or mass trauma. Other risk factors include being female with comorbid mental illness and a history of trauma. And clearly the family and the child and their characteristics play a role. And when kids become dissociative, the likelihood of PTSD increases as well.